And usually what ends up happening is you can get stones, or you can get some kind of obstruction in the ureters, and actually they can go in and they can dilate those. And sometimes we can actually put stents in the ureters. And what I was about to say was just like cardiac catheters, you know how they can go in and put stents in. Sometimes we can put stents in the ureters as well when we've got strictures going. So, any questions about that? I want to make sure I'm clear. Okay, so incontinence, we know patients have lots of times. That's just involuntary loss of urine. One of the things that we can do with patients who are incontinent all the time is check for post-void residuals. So what does that mean? Say that again, Kim.
Urine left in the bladder after they move.
Right, and how do we do that? Bladder scan, right? Have any of you seen a bladder scan?
Yes.
Yes, it's a great piece of equipment that came out not too long ago. I think it's been around maybe a whole 15 or 20 years. And so the really nice thing is we used to have to catheterize people to understand what their post-void residual was. Now we can just run a bladder scan over the bladder and we can see how much urine is in the bladder, which decreases the risk of infection. It's 2 times more common in women than men. It can be socially isolating, and it definitely causes skin breakdown, right? So socially isolating, why?
They don't want to
They don't want to what?
They don't want to wet their pants in public.
They don't want to wet their pants in public, right? So now what we see, we have all these great commercials about all of these new incontinent products, right, for people. And so it's good because it really is helping to get people out. And so there are a few different kinds of incontinence. Stress incontinence is something that can occur. So you cough and you pee. So you cough and you pee. That's stress incontinence, right? So one of the things that you can do for that is you can do Kegel exercises. Usually the most common cause of stress incontinence is what? Childbirth, right, exactly. So Kegel exercises all the time, practicing tightening up that muscle will absolutely help with stress incontinence. Diet therapy, drug therapy, and sometimes surgery. But most, 9 times out of 10, we're trying to stay away from surgery with this, and we're trying to teach patients, to avoid alcohol and caffeine, right? Because caffeine is a diuretic, and it can cause urgency. Acidic foods, even believe it or not, weight reduction, like a 10% weight reduction, they're saying, can help with stress incontinence and adequate fluid intake. So, we talked about stress incontinence, here's urge incontinence, okay? So urge incontinence is that commercial on TV. Gotta go, gotta go, gotta go, right? And what is the drug they say to use? Detrol. And so, so you'll see here anticholinergics, right? Ditropan. One of the reasons that patients will have urge incontinence is because of the spasms that are occurring of that large muscle, the detrusor muscle. So diet therapy, you want to avoid caffeine and alcohol, behavioral interventions, exercises again, bladder training. So how do we do bladder training? You guys know? Scheduled bathroom times, right? Ken, what were you going to say? Is that what you were going to say? All right, so this is what we do with patients. We'll say to them, hold it for 30 minutes, okay? And try to hold it for 30 minutes, okay? And then we start to increase it. So we start out with a lower amount of time, and then we move up so that we can get patients to hold. So hold it for 30 minutes. Don't go to the bathroom for 30 minutes. Then you can go to the bathroom. Even if you go 12 times a day for 30 minutes. And then in a couple of days, you're going to increase that to an hour, and so forth and so on. Even electrical stimulation, you've heard of electrical stimulation is, electrical currents are some things now that we can do, like you've heard of TENS, right, for a little machine that you hook up to your back that can help with pain management, can also help with bladder problems. Okay, so overflow incontinence is known as reflex incontinence. We definitely will use surgery to relieve any obstruction. Sometimes we'll use intermittent catheterization. Bladder compression and intermittent self-catheterization. Do you guys know what bladder compression is? Yes, Caitlin, you're doing a great job of it. Leaning over and actually compressing the bladder yourself. So, what was it? Yes, and that is absolutely right. So that's the other way is definitely leaning, pushing on it to get rid of the excess urine that's in the bladder. Drug therapy and behavioral intervention. So this chapter really is not overwhelming, the urinary chapter. Like, I think a lot of this is probably common knowledge. This is one of those things that's more like, should be familiar. Is it or is it not? I don't know. Yes? No? Okay. Functional incontinence. We want to treat the possible causes if we can. What does functional incontinence mean? Does anybody know?
More in the brain than in the actual.
Yeah, so here's the thing. I'm so confused. I don't even know that I have to go to the bathroom. Okay? So, like, I'm a dementia patient, and so I don't recognize that I need to physically get myself up to go to the bathroom, so I go. And so the problem with that is you can try to use bladder training with that, having them, put them on the toilet every couple of hours, but it doesn't always work. It's one of the hardest things. So really just toileting every 2 hours, checking them, turning and positioning them at night. And so a final strategy can be containment of urine with those patients, which is what we used to do all the time, but we don't really do that anymore. And what do I mean by containment of urine? Indwelling catheters, yes. So we don't do that anymore because we'd rather have patients be incontinent and turn and clean them and maintain skin integrity. There's much less risk of skin breakdown than there is of getting a urinary tract infection. For men, there are things that we can use. You guys remember from the bowel and bladder chapter, right? What was one of the things that we could use for men? The condom catheter, right? Okay, so the other thing I want to say about elderly people and urinary incontinence or urinary tract infections is one of the most common causes of confusion and disorientation in the elderly population is a urinary tract infection. And so if I have a patient who shows up in the emergency room, who's from a nursing home or comes from home and they're elderly, and they've had a change in their mental status, one of the very first things I'm going to do on that patient is a urinalysis. Patients, as they age, when they get a urinary tract infection, they don't run a fever. They get confused. And so very often the cause of confusion in an elderly person is a urinary tract infection. So that's one of the things that you want to think about in terms of what you would do for nursing intervention for a patient who might show up in the emergency room with confusion. Yes?
What's
And mental confusion? Yeah, so it's the infection process. So, like, it's so serious, they're like getting septic, basically. So it's the infection. You don't, as you're older, your thymus gland doesn't work right anymore. This thing that's here in the middle of your chest beside your heart, which is part of your immune system. And you don't run a fever. And so what ends up happening is you get a urinary tract infection and you don't know that you have it. And so then you get really sick. And then you start to get confused as a result of the infection. It's just a different physiology. All right, so stones, lots of people can have stones. People always ask the question, well, what are they made of? So they're made of calcium oxalate and calcium phosphate. So either the urine is too acidic or it's too alkaline. And obviously it can be excruciatingly painful when you think about a stone coming down. Well, if it's in the kidneys or coming down the ureters, it scratches and scrapes all along that tissue, so it's like very painful. And we'll do drug therapy, pain management. Lithotripsy is using, it's kind of like a sonar. It blasts the stones, okay, apart. But most times what we do when patients show up with stones is we watch them. And we give them a little strainer to take home. And we'll have them strain the urine into this strainer, the specialized strainer cups that we have, to check for little plexus stones. And if they are admitted with a kidney stone, then we'll be checking to see if the stone is breaking apart and passing. And usually it does. And usually the biggest problem is pain management with these patients. And so we have to do that. Here's the other thing. This nursing intervention is really important. When you're talking to patients about stones, you want to make sure they're drinking 2 to 3 liters a day. 2 to 3 liters of fluid a day. Yes?
Can they just have one stone?
Yes. They can have multiple stones. They can have multiple stones. They can have one tiny little stone. We're learning that it's hereditary. Like, you'll see it in families, genetic. It occurs more often in men. So men in their 30s and 40s, for whatever reason. Okay. This is what I was trying to say. Use a sound laser, the lithotripsy. And so we put patients under for conscious sedation, and then we break apart those stones. Okay, so here's another cancer that you'll see. We have what we call urolithial cancer, and those are malignant tumors of the lining of the transitional cells in the kidney and the renal pelvis, the ureters, the urinary bladder, and the urethra. The major risk factor for this, believe it or not, the major risk factor for bladder cancer, smoking. You know, so patients will undergo radiation if they need to. If they need to have a cystectomy done, there are alternatives. So sometimes patients have to have their bladder removed because of bladder cancer, and a lot of patients don't want to undergo this process. It can be not great. They don't want to have a bag on the outside of the body. But just like you can have a colostomy, we can create a little conduit, and your ureters are sewn together, they're folded through the abdomen, and they're connected. You can connect it to a bag. So, and that's how we manage that process. So you don't need your bladder. You can take it out and you can function. Okay, let's see. I don't know. We pretty much talked about the other 2 slides. Are there any questions? It's also referred to as a spastic colon. Patients with IBS, irritable bowel syndrome, we really don't know the cause of irritable bowel syndrome. We really think it's one of those autoimmune disorders for whatever reason. Women are 2 times more likely to get it. We don't know if there's some immune genetic factor associated with it. So they have chronic diarrhea, it's recurrent. Stress and anxiety definitely make the symptoms worse. And we want to just, when we're doing our assessment, we want to ask about bowel pattern. Do they have mucus or bloody stools? Do they have left lower quadrant pain, cramps, fatigue, and flatulence? There is a thing that we can do to test for IBS. It's called the hydrogen breath test. If there's an overgrowth of bacteria, believe it or not, you produce too much hydrogen, you breathe it out, actually. So there's this special breath test that we can do. Also, we ask patients to keep a food log. We try to help them identify foods that might be irritating to them what the stress is, a food journal, what it really is. And then again, holistic treatment for IBS. It's really one of those frustrating things in terms of treatment, because lots of times we don't know what the problem is. One of the great things that we've developed and paid more attention to these days, though, is probiotics, right? So where do we get probiotics? Yogurt. But we can also buy them all in the yogurt. Activity, right, it's all we hear about in the commercials, right?
Sauerkraut, things that are fermented also.
Fermented, that's right. Remind me of the foods that are fermented.
Sauerkraut, kimchi, can't think of anything.
Yeah, like sauerkraut's a fermented food, right, exactly. So that's another place we can get
What's that
probiotics.
stuff that's really popular right now? Yeah, I love that. Kombucha.
What is it?
That's really popular.
That's right. Okay, great. So probiotics, okay? So we really need to talk to patients about using that and also keeping themselves really hydrated. Now, we're going to talk about some of the common causes of lower GI. We just talked about upper GI bleeds, but ulcerative colitis is one of the common causes of lower GI bleeds. Polyps, colon cancer, diverticulosis, and hemorrhoids. Now, here's what I want to say. We'll get to colon cancer. Colorectal cancer, this is just showing you where it occurs in the body. Now, your book says it's the third leading cause of cancer-related deaths. It is not. It is the second leading cause of cancer-related deaths behind lung cancer. All right? So, and I posted a link to CDC. I won't go there in the interest of time, but if you don't believe me, you can go read about the stats. So I don't know why the book has it wrong, but it's not right. And the reason I want to stress this is that colorectal cancer is a silent killer. And so what is everybody supposed to have after the age of 50? So one of the things that we have finally figured out that's really kind of nice is that we can also do fecal occult blood testing. And we can do fecal occult blood testing 3 days in a row, 3 different stool samples. And there's certain dietary restrictions. You want to tell people not to eat red meat when they're doing this. And we're finding that for people who are low risk can be as effective as having a colonoscopy. However, having said that, so can you imagine my thrill when my doctor told me that, right? Because I'm over the age of 50. And she's always saying, you got to have a colonoscopy. And yes, guys, I'm a bad nurse. I'm like terrified of that. So I was really happy when she said I didn't have to have a colonoscopy. And you will find that patients feel that way too. So I think, but the thing I want to say about this is it's no guarantee. All right, so the best, the gold standard really is a colonoscopy, okay? So if you have anybody in your family who has a history of it, you need to have a colonoscopy. It's the best way to detect colon cancer. Lots of times colon cancer isn't picked up until it's in the 3rd or 4th stage. It is such a silent killer. So we want to talk to patients about, again, having, a good diet, making sure that they're, also drinking and smoking, all those other things can contribute to it, but a diet high in fat is thought to be linked to colorectal cancer as well. So one of the things that we can also say to patients is we can do some lab tests. So there's this thing called CEA, it's carcinoma, embryonic antigen. It should be under 5. That's a test that we want to see under 5 micrograms per liter, I think is what it's saying.
What's it called?
It's CEA, so it's right here, and it's carcinoma, embryonic antigen. HLA is hemoglobin hematocrit, LFT is liver function test, we're going to check that. These are just some of the diagnostic tools that we can use. Avoid aspirin, vitamin C, and red meat for 48 hours when you're going to do that fecal whole blood test. Yes, Christine.
Did you say the CEA test should be, or just less than 5?
Should be less than 5.
It should be less
Yeah,
than 5.
it should be less than 5. We can do surgery, and we often do surgery. So when we determine that patients have colorectal cancer, we need to do surgery. We can do a colon resection. Sometimes we're lucky we can get it all, and we don't have to do an ostomy on the patient. Sometimes we have to do a colectomy. Sometimes we have to do a colostomy. Sometimes we have to do an ileostomy. These are just different anatomical positions and different ways of managing the colon cancer. And so these are the different kinds of ostomy. This one is the ascending colostomy. It's done for right-sided tumors, and you can see this is the stoma right here. Sometimes we'll do a transverse double-barrel colostomy, and that can be used in emergencies such as intestinal obstruction or perforation because it can be created quickly. And so there are two stomas with this. This can be reversed too. That's the other thing that can happen if it's for intestinal obstruction. Sometimes when we do ostomies on patients who come in with a strangulated bowel, we'll do an ostomy, a temporary ostomy with those patients, and 6 months later they'll go back in and they'll have it reversed. So it doesn't necessarily have to be permanent. And this is a descending colostomy for left-sided tumors. And this is a sigmoid colostomy that's done for rectal tumors. Sometimes we can take out also for rectal tumors, I don't know, there's I don't know if you've ever heard of this or not. Sometimes patients actually need to have the rectum removed, but there's this thing called the J pouch that we can actually build with intestinal tissue and make this J pouch sac and teach them how to have regulation over actually emptying that pouch, which is internal. It's a pretty complex process, but it's better than having an ostomy for some patients. That's the choice that they want. The risk with that, too, again, is that you can definitely have incontinent stool, which can be embarrassing. So if patients are going to have surgery, obviously we're going to do bowel prep, unless it's an emergency. If they come in with a perforation, they come in with obstruction. You've got to make sure that patients are at least MPO for how long? Do you guys know?
For operations?
Yeah, for operations. At least 6 hours. So if you've got a patient that needs emergency surgery, you're really shooting for 6 hours if you can, to hold off until the patient's been MPO for 6 hours. Now, CWOCN is wound ostomy care nurse. It's a specialty. There's a special certification for it. 18 months to become a wound ostomy nurse. And it's an amazing role. You can teach people how to manage ostomies as well as do wound care. So taking care of a brand new colostomy for patients is overwhelming. There's a lot of, people are totally freaked out, right? Because they can't have a bowel movement in a normal way anymore. So now all this stool is up front in the abdomen instead of behind in the rectum where it needs to be in the toilet, right? So it's a psychosocial impact is huge. People often don't want to look at it. You'll have spouses that don't want to help each other take care of it. So if you bring in a wound ostomy nurse who has really good expertise and understanding of all kinds of tips and tricks, and there's even sex pouches for patients who have ostomies so that it doesn't get in the way, right? Think about it. It's on the abdomen now. So it's important. Those are all kinds of things that are really important. So check the skin, the pouch. You want to make sure that when you're looking at ostomies, you're doing a really good job of maintaining good skin care. I hope that you all get the chance to see what one looks like. You always want to make sure there's a good seal so there's no acid that's leaking underneath and breaking down the stoma in patients' habit. There are certainly dietary measures to control gas and odor. There are different pills that we can put into the pouch nowadays that can definitely eliminate the odor. And we want patients to absolutely resume normal function. Now, there are a couple of different kinds of obstruction. One of the things that we'll see is mechanical, when the valve is partially blocked by problems outside the intestine. Sometimes when people have surgery, they develop things called adhesions, and the bowel literally sticks together, and those adhesions end up causing an obstruction. Also, you can have tumors, you can have Crohn's disease, and also so you can have non-mechanical obstructions. That is called a paralytic ileus. That non-mechanical obstruction is very different from mechanical. It has to do with neuromuscular problems. So the GI tract stops working the way it's supposed to, and you get peristalsis, and you don't get, or excuse me, you get a paralytic ileus, and you don't get movement of the intestine. There's no peristalsis. It literally stops working. It freezes up. This is just a picture of mechanical obstruction. Intussusception is when the bowel actually goes inside itself. That's not as dangerous as this one. This is life-threatening. When patients come in with a strangulated bowel, we really have when they've got a volvulus, they're going to have intense pain. We really need to get them the surgery right away. Most of these will result in peritonitis because the bowel is so twisted, it causes this back pressure and then it explodes, and you get peritonitis in the abdomen. And so it can be caused by impactions, it can be caused by tumors, and also be caused by diverticulitis. So really important to rule this out. Mechanical obstruction, you're going to get colicky pain if it's in the colon. If it's in the small intestine, you're going to get this mid-abdominal pain. Non-mechanical, this is the difference. It's just going to be constant and diffuse pain. So, mechanical obstruction, you're going to get colicky pain. Non-mechanical, it's going to be constant and diffuse. This is a quick run through. Common abdominal hernias, okay? So most times we're going to see patients that need surgery with what we call an indirect inguinal hernia. And this is actually an outpouching of the intestine through the inguinal ring, and that also gets strangulated. Sometimes you'll see direct, and that's an area of weakness through the muscles. This is a femoral hernia, this is an incisional hernia, and this is an umbilical hernia. Now, the only time that we don't want patients to deep breathe and cough is after the repair of the hernia, right? Because you don't want to cause the hernia to come back. And they'll fix these hernias down here, and they'll actually put a mesh in to strengthen that part of the wall so that you don't get that occurring again. This is just showing you polyps.
Maybe I missed it, but going back to the hernia, what are the complications?
The complications of hernias.
Is one of our tests.
Yeah, it is. Right, so some of the complications of hernias are the things that I was talking about before, like they can get strangulated, right? And so the patient, or it can cause obstruction, so you can need surgery. Yeah. So, and the most common cause of that really is this indirect inguinal hernia. So you guys can see, right, this is a big outpouching of the intestine through that inguinal ring, and it gets strangulated. And so you'll have very common in men in their 20s, we see it happen. So that's the complication. Polyps, this is what they look like. They can cause obstruction, rectal bleeding. Some are malignant, some are benign. If they're malignant, they're usually an adenoma. And I think last but not least on this slide is hemorrhoids. No, a couple more. All right, so hemorrhoids, You know, you want to be careful when patients have hemorrhoids. You can have a lot of profuse bleeding, but I think the thing that freaks patients out is when they go to the bathroom and they see bright red blood in the toilet. 9 times out of 10, it's hemorrhoids if it's bright red blood. When it's dark, you know, when it's black and tarry, that's when you've got to worry about an upper GI bleed or cancer. So, you know, these are some of the causes: prevention, fluids, fiber, healthy weight. I don't think there's any test questions on hemorrhoids. And then, yes.
I do have a
Okay.
I had a patient last semester, and I was quite surprised that it was really about it. Isn't there like surgery or
Yeah, I just want to make this comment. You can do hemorrhoidectomy with patients, but it is extremely painful, and sometimes it has to be repeated.